Welcome back, everyone. I hope you can hear me. Um, Welcome back from break, and welcome to the second panel, Ecosystem Approaches to Improving School Health. I'm Erica Spots. I'm from the Office of the Behavioral and Social Sciences Research at the NIH. And I think we should let's get started with our first speaker, who is Sarah Stanton of Johns Hopkins University School of Nursing.
Hi, thanks so much. And for those of you who are back from break, thanks for coming back. Just a few transitional comments before we start. Today's day is about school health, and we were asked to talk about a neighborhood approach, which is obviously around the schools. We also, you'll be hearing from our Vice Dean, Bob Atkins, later in the day. We also have school nurses in schools in Baltimore City. The city school system came to us and asked after COVID to help with that. And so we gathered together with Morgan State and Coppin State, and each have 5 schools, so 15 altogether, where we're supplying the school nurses, and he'll be talking about that. But for this, I'm talking about what we call neighborhood nursing. And we often think of it as like a school nurse for the neighborhood. So if you picture, just to open your mind to a different kind of health system. Next slide, please. We've all seen versions of these slides for 30 years. I'm just going to show you one, but essentially we spend much more money as a percent of our GDP than any other wealthy country. You can see that the closest peer is Germany, and they spend 12.8% of their GDP, and we spend 18%. And of course, we get less for that. We have more chronic disease than 183 other countries. We have shorter life expectancy than all of the other wealthy countries. And while this is, it's a waste of life and of money and of happiness and joy. And but the fact that we spend so much actually gives us room to be able to do creative things, because we already are spending so much that there's a lot you can do to spend less and invest in interesting ideas. Next slide, please. I think this is all obvious to everyone on the call of what we are currently, but just to point it out so that I can contrast it with neighborhood nursing. In the current health system, I'm going down this left side of the slide. It generally happens in schools if you're from this call, but generally in clinics and hospitals. We tend to diagnose ailments that already exist. And when there is something innovative, it's often on high cost users, meaning people who are in and out of the hospital a lot, people with, say, congestive heart failure, or people who call 911 a lot. The solution is often designed only by experts. And we tend to test them in terms of research with single cause methods like randomized controlled trials. And not to say that all of those aspects aren't important, but they're not enough, right? We're not getting value for our dollar in terms of what we spend medically. And so an effort like neighborhood nursing, and school health is part of this, is to be much more out in the community where people are, where people live, where people play, where people learn, importantly. And in neighborhood nursing, the assessments are much more holistic, just the way that you would in any preventive kind of model, and really building around people's goals and strengths. And school nursing and neighborhood nursing focuses on everybody, right? Not just the people who are ill or likely to be costly to the system. Neighborhood nursing is designed with people with lived experience and experts. And then in terms of the research around it, we know we can't just do randomized controlled trials, that we need to look at complex adaptive systems, qualitative methods that complement quantitative and cost methods. And I'll be talking a little bit more about the research later on in this little talk. Next slide, please. So we started neighborhood nursing. We started by listening for a good long months to neighbors, and we started in a neighborhood called Johnston Square, which is very close in East Baltimore, very close to Johns Hopkins School of Nursing. And we initially, in our first listening, I had imagined we would be going door to door, and I'm a nurse practitioner with a PhD, and I used to do house calls in West Baltimore to people who were homebound. And I would knock on the door, and often people would need to drop their keys from the second floor, for example, because they couldn't get downstairs. Or sometimes someone would answer the door and they'd be on their hands and knees and would let me in. And I very much have patients like that, people like that in my mind, and people who can't get out. But the neighborhoods we were talking to, neighbors said, please start at trusted places. Please start at community hubs that we will come to. So that's how we've started. This picture is in a senior high rise. And this was a woman who started regular check-ins with a nurse there who had been coming once a week. She wasn't feeling well. And together they developed a care plan around all of her strengths and goals, and particularly around ongoing blood pressure management. And in that building, only 11% of the people whose blood pressure we measured was normotensive. The other 89% was stage 1 or stage 2, or really acute blood pressure, which is important to note because everyone in that building was on Medicare. So they all had insurance. Insurance is not enough. And Senator Sanders, Bernie Sanders, came to visit that building with us. And one of the people who came to see the neighborhood nursing said to Senator Sanders, I have insurance and I have many chronic conditions, and I don't go see my doctor. I see these nurses because they're here and I trust them. And those two things are essential to care and to who nurses are, nurses out in the community, that being there and being trustworthy. If you could click on the next slide. So this is a granddaughter of the older woman, and she had been living with her father in abandoned homes and couch surfing because they didn't have a house. And she hadn't had the medical care that she needed, and she was unable to start kindergarten. The community health worker in the neighborhood nursing program secured medical insurance, and the nurse, assessed her more from a nurse perspective and got her a pediatrician appointment within 3 days. And next, I think there's one more click on this slide. Within 6 days, she had a well child visit, developmental screenings, a dental referral, and she was enrolled in and attended her first day of school. So this is this is just two people in one family, but shows you the benefit of being neighborhood based and being able to take all comers, and to have a model where you can see the whole family. And I know that in school health, there are models where, grandparents can be seen in the older siblings and younger siblings. And I think if we think broadly around neighborhoods and schools, that it's a benefit because as I mentioned, I used to do house calls and I would walk right by the other patients and the other people, heading right to the older adult that I was there to see. But, if you walk by the 2-year-old and the new mother and the older sibling, you're missing out on so much help that could be provided. Next slide, please. So it's kind of an obvious question. How do we get something like this to everybody? Next slide. So neighborhood nursing is based on Costa Rica and some other countries that have a universal preventive model. And so the idea isn't to replace what excellent medical care and nursing care there is in the US. The idea is to have a universal platform that kind of is the glue between school nursing and having school nurses in libraries and paramedics who are doing interesting work and community health workers who are helping new moms, but to be that underneath, that glue underneath that everyone can reach, that everyone can reach a nurse or a community health worker by text or by app. And the nurses are in the laundromats and the libraries and door to door and at senior centers. And it's strength-based and preventive. Longitudinal. It's not a student model. I'm a dean of a school, but this idea isn't that students would do this. And in Costa Rica, the way it works is the entire country has geographic zones. They call it everyone's geographically impaneled. And on the regional level, they look at what zones are doing well or not based on metrics, based on premature births, based on rates of preventive care. And if a zone isn't doing as well, they first make sure it's being managed well. And then if it is, they provide more resources to it. So it's universal, but it's a targeted universality. And so that I think is an excellent way of moving forward in terms of programs where we're never going to just, it's really important to serve everybody. And we want health for all Americans. But on the other hand, as we know, there's a long history of some populations being more marginalized or some populations not having access. And so this targeted universality means that you can offer the same thing to everybody, but you can make sure that you are making up for some and digging deeper and more comprehensively in with people that need that. Next slide. So as I mentioned, we started with listening, envisioning, and engaging, responding. We've been piloting since 2024. We have raised money to actually do the model, meaning actually the nurses and the community health workers. We started in East Baltimore in this 2024 bubble with the piloting. University of Maryland is starting it in West Baltimore and Sandtown, Winchester in this year. And then we are starting in Somerset County in 2026. That's a rural area of the Eastern Shore of Maryland, and then a suburban site in the following year. That does not mean that everyone will have universally had access, that will have enough nurses and community health workers for all of those neighborhoods before we get to the next one. The idea is to stand it up in multiple kinds of areas to learn what do we need and how does it work. And the money that we've raised so far predominantly is philanthropic and foundations. And then we've been talking to insurers about paying into it. And the overall view is for policy sustainability that I'm happy to talk about. Next slide, please. So because we're all here talking about NIH priorities and what NIH should be doing, I think that the two big questions in neighborhood nursing are how do we sustain it through policy, which we've just gotten one grant about and close to getting another grant. And then the other big question is how do you measure the impact? How do you know that this is working and what does working mean? So next slide, please. Of course, you can look at individual health outcomes, and we are. So people's blood pressure, reducing preeclampsia, postpartum death, increasing developmental health checks, improving depression and anxiety. And of course, we're looking at reducing some of the costs like emergency department visits, hospitalizations, and readmissions. And those are important. Backing up before that, we also, of course, need to understand the actual model. Like, does it make sense to have the same number of nurses and community health workers, like a 1-to-1 ratio? Should there be more community health workers in different kinds of neighborhoods? Do we need different staffing? At what point do you layer on primary care? Do you layer on primary care just for people who don't have it, or they've got it but they can't get into it? Is it better to do the primary care kind of almost like acute care, and then you connect them somewhere else, or would we have a whole army of neighborhood nursing nurse practitioners as well? So some of those about the model too are really important questions. Next, click on the slide. Okay, next one. Oh, there. Okay. We also, Jessica Gill, who used to be intramural at NIH, at NINR, is now at Johns Hopkins, and she is able to measure about 2,000 proteins from just interstitial fluid. And so there's a big opportunity to just open your mind for a minute for understanding population health kind of on a biomarker level. So I'll give you an example. You go to the hospital to see if your troponins have raised, if you think you might have had a heart attack. We might be able to, in the near future, be able to tell if someone has had that just from zeroing in on them from a monitor they would have in their arm. And from a population health level, we could even be seeing if it's rising. There's so much work to be done in terms of trust and the trust of data and trust of universities and communities, which is another, a really important research area. And just a couple other examples of Dr. Gill's work. She is very close to being able to tell about white matter neurodensities in the brain from interstitial fluid from something you could wear in your arm, like a glucose monitor. And so we could, we think about that if you had that on a population health level, or a population level. So the impacts that we could be having with neighborhood nursing are some of those individual health outcomes, but also down to the cellular level, and then also wider out to the societal level. Like maybe there's be more social capital, more social trust from people having the same nurse, for example. Maybe we could get people more involved in their health and in discussions about health with their neighbors. Next slide, please. Right, so I was just mentioning population health outcomes, like what is the value of universality? Maybe communities will be stronger. We posit there'll be more trust in healthcare and health providers if, sort of echoing what the gentleman had said to Senator Sanders, that if people are out in the communities, and it may redound back to the larger health system, the hospitals and clinics. Next slide, please. And next slide again. All right, one more. Thank you. Okay, so if you press, okay, so this is an idea of using qualitative data. So these are two different stories that are zooming by. You can turn them into variables and then map them based on the words in them. And then you can also geomap them in terms of where they were said and the neighborhoods, and if with the correlations between the words, and be looking at communities. And then you don't lose, you still have all of the words. So there's a database of the stories, but you've been able to make some quantitative calculations based on all of those. Next slide. And last slide, I think. So I kind of wanted to end, and I'd love to take questions, that, Francis Collins, when he was leaving NIH, he said in a few interviews that there'd been so much advancement in basic knowledge, but that it would only impact if there's trust and better ways of developing healthcare. And we've always been trusted, and we think that universal preventive care will build that trust, and that together that would help build the science. And so that our developing better care models is really important to being able to develop the science. And I think that's my last slide, and I'm very happy to take questions, or I'm not sure if it goes on to the next speaker and then there's questions at the end.
Thank you so much for a really fascinating talk. We are going to have all the speakers and then take questions, which leads me to remind everyone to put their questions into the Slido as you have them, and then we'll get to them after after the third speaker. But our next speaker is Natalie Colabianchi from the School of Kinesiology at the University of Michigan, speaking about the influences of parks and playgrounds on child health. Natalie?
Thank you.
Oh, there you are. Okay.
I'm excited to be here to talk about parks and playgrounds and their positive effects on child health. Next slide. And in fact, the health effects of parks and playgrounds on child health are far-reaching, and they span from physical health to mental health, social benefits, cognitive benefits, and environmental benefits, which can also lead to improved child health. Next slide. So when we think of health benefits of parks and playgrounds on child health, many of us probably think about the physical health benefits, and there are a number of them that are derived from the movement that's often occurring on parks and playgrounds, such as increased activity, improved motor skills, increased muscular strength, especially from activities like the one the child in the picture is engaged in, improved cardiorespiratory fitness, being at a healthy weight, and improved sleep. And these benefits have been found across many studies, Note some of the studies look at parks and playgrounds and their use specifically, while others are looking at associations of whether they have parks or playgrounds in their area. And some are generally looking at green space or even nature areas. And of course, being physically active leads to a host of other physical health benefits, including increased likelihood of a healthy blood pressure, healthy blood glucose levels. So there's this cascade of physical health benefits that come from being physically active in a park or playground. Next slide. And parks and playgrounds also benefit children's mental health. We see increased wellness and lower stress and anxiety associated with parks and playgrounds. And interestingly, this is an area where there's good evidence that even if you're just looking at a park or nature area, even if you're not using them, you can accrue these benefits. Next slide. So parks and playgrounds are an important avenue for children to develop social skills. These spaces offer children opportunities to interact with their peers in an unstructured environment where they can practice important social behaviors like sharing, taking turns, resolving conflict. Playing on the playground often is free play or game play, where children are learning to navigate rules, make decisions as groups, and manage disagreements. And then finally, children and the parents that come to these parks and playgrounds with their children are often fostering a sense of connectedness and solidarity within their community. Next slide. Activities in parks and playgrounds have also been associated with improved cognition, including attention restoration, better concentration, and improved memory. And so, for example, children with attention deficit hyperactivity disorder who were age 7 to 12 took a 20-minute walk in 3 environments, one of which was a city park. And they found that the children concentrated better after the walk in the park, and that was compared to walks downtown or walks in their neighborhood. So there was something specific about being in that park that increased their concentration. And they had large effect sizes, and the effect sizes were similar to those seen from medication use. Next slide. And lastly, parks and playgrounds can lead to environmental improvements such as noise and heat reduction and improved air quality. And then these environmental improvements in turn are associated with better children's health, including, for example, lower asthma symptoms. Next slide. So with all these amazing and extensive health benefits, Dr. Howard Frumpkin, a senior vice president at Trust for Public Land and co-editor of Making Healthy Places, says parks and green spaces have public health superpowers. So this is especially true given that parks and playgrounds are often no cost or low cost to use. So we know we have this amazing tool to positively influence child health, and the question is, are people using them? Next slide. So one good estimate of how people are using parks and playgrounds is from a national study completed by Deborah Cohen and others. And in this study, they sampled 174 neighborhood parks in 25 major cities, which had populations of greater than 100,000 people. And they visited each park 3 times on each of 4 days, spreading their visits throughout the day. And they observed the number of people who were there. They classified what categories they were in terms of their sex and their age group. And then they also noted what type of level of physical activity they were engaged in terms of sedentary, moderately active, or vigorously active. And they found about 20 people at a park per hour. And the average park size in their studies was just under 9 acres, which I looked is roughly 7 football fields. So if you spread those 20 people out across 7 football fields, that's about 3 people in a land area about the size of a football field. So that's pretty low usage. Of course, we know usage varied by the time of the day. Across age groups, children and teenagers made up about half of the park users, which of course 50% is greater than their percentage in the general population, suggesting that children and teens are using parks and playgrounds at a rate higher than their population size. I also mentioned they documented people's physical activity levels, and what they found was that most people, about 61%, were in the sedentary classification. Amongst teenagers, that dropped to 53%. It doesn't mean they were sedentary the entire time they were in the park, but at the time that they were observed, they were in this sedentary classification. Let me mention, this study was done in mid to large cities, those over 100,000. I've also completed some work in rural areas, specifically in South Carolina, where we looked at utilization of parks. And again, in our observations, we found generally that utilization was low. It was actually a little bit lower than what we were seeing in these national studies. And Jane Jacobs, who's best known for writing the book, The Death and Life of Great American Cities, talks specifically about low density areas, park areas, and talked about the importance of having special demand goods. So something like a swimming pool or concerts or plays that's going to draw residents out into these parks, because in these low density areas, they're less likely to be used for general park use. So that's certainly an area where we can use more research. Next slide. So we're seeing relatively low use. What are attributes of parks and playgrounds that lead to higher use? There's a variety of elements that have been shown in the research to encourage utilization of parks and playgrounds, many which were identified by Dr. Badimo Rung. And the first and most important one that people talk about is accessibility, or the ability of people to get to a park. So utilization is significantly greater when parks are in a close distance. But we can also think about accessibility once you get to the park, meaning are the park features that people are seeking to use, is it reasonable to get to them from the entrance? Thinking about how features are co-located. So if you're coming to use the playground, what are the other features that are nearby, and are parents going to feel comfortable having their children there? A second element, which is very important, is features and amenities at the park. So people come to a park for a specific purpose, for the children to play on the playground, to do a team sport, to go for a walk. So if the park cannot support the specific activity they're looking to engage in, then they're unlikely to use the park or playground. And then along with features, amenities are certainly important. So is there parking at the park? Are there bathrooms that can be used? Are there benches to sit on? Are the play features shaded? All of these things can be important decisions when people are deciding whether or not to use a park. The condition of the park or playground is also important. So people are more likely to use the park or playground when the equipment is well maintained, when the features like a playground surface is considered a safe place to play on. And then also, as people are thinking about the conditions of a park, we're also looking at whether or not there are incivilities present. So incivilities in the context of playgrounds and parks can include things like trash, or empty alcohol bottles, or graffiti. And when incivilities are present, people are assuming there's been a breakdown of the social order of the community. So it gives them information, and it potentially makes them feel unsafe being in the environment. And we know that safety is an important factor of park use. So our last three elements: when a park or playground has inviting, attractive elements, it can also encourage use. But beyond these aesthetics, whether or not the park or playground has shade, whether it's too hilly, will also affect whether people will use the park or playground. And as I mentioned, safety is a key factor in park use, especially when we're talking about parents deciding whether to let their children use the park or playground. And we found in the research that both perceived and objective safety is correlated with park use. And then finally, the policies of the parks are important: the hours of operation, whether there's a cost to engage in the programming, and what rules are out there relative to park and playground use. Just to mention, these features correspond to things within the park, but it also has an effect on the area around the park. So for example, safety of the park is important, but also the neighborhood in which it is embedded can be important. Next slide. And since we're talking about children, I'm a built environment person, so I spent a lot of time talking about the built environment, but of course parents play a crucial role in shaping whether and how children use parks and playgrounds. So their attitudes, their behaviors, their decisions directly influence children's access to and engagement with these spaces. So parents who value outdoor play, who prioritize physical activity, they're going to be more likely to encourage their children to visit parks. And they may be actively going with their children to play in the parks and setting up play dates there. So we know when parents model this behavior, children are more likely to follow in that behavior. Parents are often supervising their younger children, so it means that the children's ability to use the park is going to be dependent on the parents' availability and willingness to go to the park. And then finally, the parents' perceptions, again, about safety, cleanliness, amenities, that's going to play an important role in children's use of parks and playgrounds. Next slide. So moving back to that national study I'd mentioned, they also tracked what areas of parks and playgrounds that people were using, and the most common locations were lawns, playgrounds, sidewalks, and then the various sports fields like baseball fields and soccer fields. And the areas where children were most likely to be engaging in moderate to vigorous activity were in the walking loops, in swimming pools, in gymnasiums, and in skate parks. Importantly, as part of this research study, they also documented whether the areas were accessible, usable, or supervised. And supervised means there was a person in charge who was managing and directing activities, like a park staff person. And when there were supervised activities, they saw higher use in that area, suggesting the importance of having programming to attract users to the park or playground. Next slide. So I just talked about the importance of programming at parks and playgrounds to increase utilization. Now I want to tell you about a study we did where we found that having green space nearby was important for community programming. And this was a study of over 5,000 families in 130 communities across the U.S. And within these communities, we spoke to about 10 key informants about the programming and policies they had in their communities. And in the analysis I'm talking about now, we look specifically at programs and policies that were associated with reduced sedentary time. And we examined whether having these programs in the community of this type were associated with less sedentary behavior in children aged 5 to 15. And surprisingly, we didn't see any association between having programs in the community that focused on reduced sedentary time and the kids' sedentary behavior. We recognized it was important for the kids to have something else to do if they were being asked to reduce their sedentary time. So we looked at whether it mattered how much green space they had in their community. And as it turned out, in communities where there were high levels of green space, the association between having programs and policies that reduce sedentary time was associated with less sedentary time, even after controlling for important factors like neighborhood socioeconomic status conditions. But in areas that didn't have high levels of green space, there was no association. So again, it reiterates this importance of having this programming as well as the supportive environments to encourage healthy behaviors. Next slide. So I've been talking about parks and playgrounds in the community, which was our charge. But for the last part of my presentation, I'd like to switch gears a little bit to talk about playgrounds in the school environment. And I know you heard a little bit about this from Dr. Hager in an earlier session. Of course, some elementary and middle school schools have playgrounds and other spaces for play. And these spaces provide opportunities to be active, to be social, to engage in creative play during the school day. But they're also an important opportunity to serve as a community resource after school, on weekends, and in the summer. Next slide. So a while back, I was involved in a project called School Grounds as Community Parks. And the idea behind this initiative was to renovate the schoolyards, upgrading a number of elements, including the play spaces. And the community members, including the children in the schools, were involved in selecting the play structures. And importantly, the school grounds were made open to community members outside of school hours, thereby making them community parks where parks were otherwise limited. And we received a grant from Robert Wood Johnson to evaluate whether these changes resulted in more use in the evenings and weekends relative to utilization at playgrounds at schools that had not yet been renovated. And we evaluated this using some of the same techniques that I had talked about in that national study. So we went to the sites, we had directly observed who came to the spaces, we documented characteristics about them, such as their sex and age group, documented the characteristics of the space, including whether or not there was supervised activity. So we spent time at 10 schoolyards that had undergone renovation, 10 schoolyards that didn't get renovated, to determine differences in utilization and activity levels outside of school time. All right, next slide. Failed to mention I'm fighting a cold, so hopefully I won't have a coughing spell. So what we found was more people used the renovated playgrounds outside of school time relative to the non-renovated playgrounds. And the children were more physically active at the renovated playgrounds compared to the control playgrounds, especially boys. But overall use was low. Excuse me, actually overall use was low with one exception when there was programming by a local community group, and then actually utilization was quite high. Next slide. So this is one example of a success story of the benefits of establishing shared use agreements. And shared use agreements refer to an arrangement, often formalized through a written agreement, where a school allows their facilities like playgrounds, sports fields, and basketball courts to be used by the public during non-school hours. And typically this is established through a partnership through the school district and a local government or a community organization or a nonprofit, with the goal of providing safe nearby spaces, which can lead to stronger community connections and more efficient use of resources. And the Trust for Public Land estimates that opening up these schoolyards outside of school hours could help address the lack of park access for nearly 20 million people. Next slide. Sorry, you'll have to watch me fight through this cough. So I'm going to wrap up by talking about the roles that nurses can play in promoting child health through parks and playgrounds. So first, nurses can champion efforts to expand green space access in neighborhoods and school communities. As part of their evaluation of the social factors that influence health, nurses can consider the role of parks and natural environments. And nurses can provide education to children and families about the health benefits of outdoor play and time in nature. Next slide. Nurses are also critical members of interdisciplinary teams, working in concert with other professionals in education, public health, urban planning. Nurses can work collaboratively to implement initiatives and advance research on the positive aspects of green space on children's well-being, and bring that nursing perspective to the design and evaluation of programs that connect children with healthy outdoor environments. I've worked in a number of community-based collaborations and have seen firsthand the critical role that nurses play in these community groups. And I think it really speaks to what the speaker before me said about the trust that people have in nurses. Next slide. And I will close and talk quickly, mentioning an initiative of the Trust for Public Land is doing in concert with the Urban Land Institute and National Recreation and Park Association, that everyone in the U.S. should have access to a quality park within a 10-minute walk of their home. We're about 100 million people shy of that goal, including 28 million children. But given the strong role that parks and playgrounds play in a child's health, I hope we see progress made toward this goal in the years to come. Next slide. Thank you so much, and I look forward to your questions.
Thank you so much. Again, we'll take questions after the next speaker, who is Christopher Browning from Ohio State University Department of Sociology, who will speak about social spaces and youth development. Thank you so much.
Thank you. I'll be talking today about neighborhood schools and school neighborhoods, primarily from an activity space approach. Next slide, please. Just a quick acknowledgement of the research team for the Adolescent Health and Development in Context study, which is the main data resource I'll be referring to today. Funding from NIDA, NINR, NICHD, and the WT Grant Foundation. Next slide, please. Okay, so I'm going to give you a quick overview of neighborhood and school research. This primarily comes out of a neighborhood effects tradition of research in social science. I'll talk to you about the adolescent health and development and study in context study design, and we'll be addressing a number of questions that I think flow from some of the research on neighborhoods and schools and then point to future directions. Specifically, I'll look at the allocation of time to home neighborhood, school neighborhoods as a relevant exposure space for kids, and then perceptions of school neighborhoods. Next slide, please. So school and neighborhood research, I think, for the most part, has been residential neighborhood centered. That is focused primarily on features of the neighborhood with the assumption that schools reflect the neighborhood composition and functioning. In this sense, schools are a mediator of neighborhood effects, but don't exert their own independent causal effects. Other approaches include the assumption that neighborhoods and schools are mutually influential. And I give you an example here, early example, Clarence Perry's neighborhood unit, a highly influential plan for a neighborhood that has schools here represented by community center and circled in red there as the literal central location of a neighborhood, and one that is not only influenced by neighborhood, but also feeds back onto neighborhood and is a source of cohesion. Neighborhoods may also moderate the effects of residential contexts, and there has been a substantial literature on the role of neighborhoods in, for instance, buffering the potentially adverse impact of living in a low-income neighborhood. And then some research looking at schools as the causally relevant setting. That is, if one controls for effects of school contexts on youth outcomes, often neighborhood effects will disappear in that approach. Next slide, please. So we come at this from again, activity space approach, considering schools as one very important routine activity location among many that youth encounter on a regular basis. We view this as important in part because school locations are increasingly uncoupled spatially from residential neighborhoods. That is, youth are, for various reasons, including school closures, particularly in low-income neighborhoods, opting out of local schools, youth, again, primarily from low-income neighborhoods or disproportionately from low-income neighborhoods, are traveling further to get to their school. So this leads to the question of whether school neighborhoods, for those youth who are leaving their local neighborhood, whether these contexts are a potentially health relevant exposure space independent of the residential neighborhood. Next slide, please. So I think it's useful to think about a concrete example here. And what you're looking at is a high income census tract, a sample of youth represented by red circles, and the person-place network for this sample of youth. And you can see here, as represented by the blue squares, the local high school, and this is a sample of 11 to 17-year-olds, is highly central in this person-place network. Many of the youth are going to the local school, no doubt because it's high quality, accessible from a distance standpoint. And this gives the local school and the interactions at the local school an opportunity to promote social cohesion within the local neighborhood. Next slide, please. In contrast, this is a low-income census tract. The youth are represented by yellow triangles. Here we see that the central location is not a school, but the community center. In fact, the schools in this network are not particularly central. And I should say that in this sample of 26 youth are going to 11 different schools. In the high income census tract, 33 kids, they're going to 6. So in this lower income neighborhood, as an example, you've got a lot of kids leaving the local area to go to a variety of different schools. That means schools are less of an opportunity to develop local social cohesion, and also result in youth spending time at more distal schools where they may have lower familiarity, fewer local network ties, fewer public social interactions that are familiar, and a potentially reduced experience of trust and safety. Next slide, please. So the key questions I'm going to address today are: how much time do youth spend outside their home neighborhood? How much time are they spending in their home neighborhood? How important are residential contexts in the everyday lives of youth? How relevant are schools in contributing to time outside home neighborhoods? How much time do youth spend in the school neighborhood, the area surrounding the physical school, for those youth who are leaving their local neighborhood to go to school? And that's the vast majority of youth, 80 to 85% in our sample. And then finally, how do youth perceive the safety of their school neighborhoods? Do these perceptions of school neighborhoods differ for girls and boys, giving potentially different uses of space for boys and girls, and also the documented increased likelihood of both perpetration of violence and violent victimization for boys? Next slide, please. Very briefly on the data, this is the Adolescent Health and Development in Context Study, Wave 1 from 2014 to 16. This is a sample of about 1,400 youth ages 11 to 17 in the Columbus, Ohio area. We have an in-home survey, but we combine that with smartphone-based GPS tracking over 1 week and ecological momentary assessment up to 5 times a day. So smartphone-based short surveys. Next slide, please. So the EMA is, again, up to 5 prompts a day. These are randomly chosen within time blocks over the course of the day. We don't have prompts administered during school hours, but we do otherwise. So we have the timing of the end of the school day, and prompts are immediately administered after that. And then the youth have about 40 minutes to answer an EMA prompt. Next slide, please. Variety of items on the EMA survey. Today, we will focus on the safety assessment, the youth assessment of the safety of the current location they're in. Next slide, please. The GPS coverage on the smartphone is continuous over the course of 7 days. And the logging of GPS points is frequent, on average about 40 seconds between points, and relatively low missingness of GPS points. Next slide, please. Next slide, please. Just a quick look at the demographic composition of the sample. This composition more or less reflects the census-based estimates of the study area. Next slide, please. So first, how much time do youth spend in their residential neighborhood? In this case, this is the residential census tract, about 4,000 people. This is by far the most common operationalization of residential neighborhood in the literature. Next slide, please. So how do we operationalize time at home? We spent a great deal of time. I had no way of knowing or anticipating how much time we would spend thinking about what it means to be at home. I'll spare you that and just say that we use the youth zone assessment of whether they're at home in the moment, or if we don't have information on the youth's assessment of location, we place them at home if they're within 30 meters of the home address. If they're beyond that location, but within the home census tract, they're in their home neighborhood, but not at home. And then finally, outside neighborhood is outside that census tract boundary. Next slide, please. So for waking time, youth spend about 60% at home, 5.7% in their home census tract, but not at home, and 34.3% outside their home census tract. So 5.7% in their home census tract looks low. In a 16-hour day, that's about 55 minutes. That's actually not a trivial amount of time, particularly cumulatively. You think about that over the course of the week, that's a substantial chunk of time. And we certainly would not argue that residential neighborhood is not an important exposure space. We have decades of research to the contrary. On the other hand, we would argue for assessing the 34.3% of time outside of the home census tract as potentially health relevant for youth. Next slide, please. So how relevant are schools in contributing to time outside home neighborhoods? Next slide, please. So our key findings here are that youth who live in lower income neighborhoods spend even less time than the average I just presented in their home census tract. And this is explained largely by the absence of schools in those home census tracts for lower income youth and higher violence rates. Next slide, please. So we can see here that for youth who have a eligible school, a school they can attend in their home census tract, they spend about 3 times as much time in that home census tract, unsurprisingly, as youth who do not. If they don't have a school in their home census tract, they're spending a lot more time outside the neighborhood. Again, this makes some sense. Next slide, please. We also note that youth who live in the highest quartile of violence, here measured by aggravated assault, spend about half the amount of time in their home census tract. That time is diverted into the home in contrast to outside neighborhood. Next slide, please. So how much time do youth spend in their school neighborhood? And this is conditional on leaving the residential neighborhood for school. Next slide, please. So first, is it the case that, as we would expect, the distance to the school from home is greater for those lower income youth? And here we see that under 60,000 household income, about 4.5 kilometers away on average, the school is from the home, that is. By contrast, households that make 150,000 or more are about 2.5 kilometers away from their school on average. Next slide, please. So what's the difference between the residential neighborhood and the school neighborhood for those who leave their neighborhood? For the lower income youth, they're going to substantially lower poverty neighborhoods, significantly lower poverty neighborhoods than their residential neighborhood, although these neighborhoods are still higher poverty than the neighborhoods, school neighborhoods and home neighborhoods of those higher income youth, for the most part. We see for those households who make 150,000 or more, that relationship reverses somewhat. So the school neighborhoods are actually somewhat higher poverty. Next slide, please. So daily average minutes spent in the school neighborhood by household income. So here's our answer to the question initially posed. How much time are you spending in that school neighborhood, conditional on leaving the residential neighborhood for school? We can see that even for the lowest income youth, under 30K, they're spending just under 60 minutes in that school neighborhood. So this is time outside of the school context, outside of school hours. 55 or so minutes, that's almost exactly the amount of time they're spending in their own residential neighborhoods. So school neighborhood here is arguably just as important, at least as important, as residential neighborhood. What are they doing while they're there? So about 1 in 5 of the EMAs that youth report from this area are reported to be at school. So 80% of those EMAs, the youth are reporting that they are not at school. So they're nearby the school, but the youth perceive themselves to be not at school in the moment. Next slide, please. So finally, perceptions of safety in school neighborhoods. Next slide, please. So here we see the basic response distribution on an EMA, a simple EMA that just asks the youth whether they agree or disagree that they're in a safe place in the moment. So the vast majority of youth agree or strongly agree, over 90%, that their current location is a safe place to be. So that's as we would expect and hope. We should anticipate that most youth most of the time will experience their current location as safe. Next slide, please. So here we have the EMA reports from within 200 meters of the school and beyond 200 meters. So we're looking at the average safety reports by income for instances where the youth are close to school and then all other instances. So how does being close to school, in the vicinity of school, compare to the average level of safety response? So here we see that the biggest discrepancy is, again, for the lower income youth. When they are within 200 meters of school, they are reporting lower levels of safety. And again, this is outside school hours. Next slide, please. For girls, this discrepancy is still there. Lower levels of safety reported within 200 meters of the school. That is still a significant difference, statistically significant difference, but it's not as pronounced as the average effect. Next slide, please. For boys, on the other hand, at the low income household income level, we see a very pronounced gap. So for youth, lower income youth who are beyond 200 meters of the school, they're reporting close to 90% agreement that the current location is safe. Within 200 meters, only 65% are agreeing at a given moment that their current location is safe. This points us to the potential for school neighborhoods to be operating differently for low-income youth, and particularly lower-income boys, and the need for more investigation of the activities and experiences of school neighborhoods for youth who are traveling away from their residential context for school. Next slide, please. So overall summary, residential neighborhoods are certainly important, but they're not a dominant exposure space for youth. Youth from lower income neighborhoods spend even less time than the average in their home neighborhood and more time outside the home neighborhood. And this is driven in part by the distance to school. Youth spend at least as much time in their school neighborhoods as their home neighborhoods. This is a new analysis. This is not a published analysis. I haven't seen as much on the use of time in school neighborhoods, but I think this is an important implication of these findings, that we spend more time trying to understand school neighborhoods as well as home neighborhoods. And finally, this may be particularly the case for low-income boys who report significantly lower levels of safety. Girls as well report lower levels of safety, but it's a more pronounced gap for boys. Next slide, please. More generally, we argue for embedding schools in the broader set of routine locations, collecting activity space information that allows us to understand the entire set of exposures youth experience and the broader ecology in which school experiences are embedded. School neighborhoods are a potentially health relevant context, particularly the case that we might want to focus on youth from lower income neighborhoods, lower income households, to understand the health relevance of these exposures. And activity spaces approaches and associated data collection methodologies offer new opportunities to investigate school ecologies more precisely. We can additionally look at, beyond just safety, we can look at the activities the youth are engaged in, who they are with among network partners, the level of structure of activities, and so on. And health sensors offer rapidly evolving methods for the collection of continuous stress measures. So some of these points I don't need to emphasize with this audience. For many of my colleagues who do study neighborhood and school ecologies, they're often not as attuned to these methodologies and their importance for understanding the well-being of youth. And that, I believe, is all I have. So thank you very much. I look forward to questions.
Thank you so much. Let's do a few questions for our speakers. If you're here, come back onto the screen. Put your, yes.
Am I supposed to discuss next?
So according to my run of show, we're going to take some questions and then you discuss. Would you prefer to discuss first?
Oh, no, that's great.
Okay. I can go either way, but that's what my piece of paper is telling me. I have a couple questions and then, sorry, I'm losing my mouse. There we are. So we have a question from our keynote speaker for Sarah. How do you see a school nurse being part of a neighborhood model? So for context, Sweden and other countries use similar neighborhood models that actually have school nurses part of the model, and it works well because they know the whole family in the neighborhood. So there's precedent in other countries, but she'd like to know how you see that fitting in with your model.
Well, thank you for the excellent question, and I'd love to learn more about how that does work in other countries. We've been thinking of it more the other way around, that the school nurses that we support would gradually become, community hubs for all ages to be seen. And since, parents are dropping kids off but I'd be interested in knowing, I think the question is more saying kind of the opposite, that the school nurses would go out into the neighborhoods. And I'd love to know more. I think it's a great question for NIH to research, to fund for external research of what are those best models and how do you extend between schools and neighborhood? Because as we've just been hearing from the other speakers, it's so fluid in terms of where people are, and you want to build on the trusted relationships, of course.
Sure. And then I have one more for you. Somebody wanted to know about your thoughts about resources or ideas for smaller scale neighborhood nursing to show small efficacy in specific contexts might help with bigger funding.
Yeah. I think it takes creativity and building on existing strengths and resources, perhaps. And so depending on where the person wrote in from, we found that local philanthropists were very excited about it, partly because, and hopefully this would work wherever the questioner is, partly because of the idea of knitting together what already is. So you're not replacing something, you're really making sure that the neighborhood nurses and community health workers know the strengths and resources of what's already in the neighborhood. And so philanthropists have been very excited about that, but especially with that we have a model built out for how it would be sustainable. In general, philanthropists, unless something's an emergency, tend not to give money to something that would just be kind of a shot, a one-time shot. But I'm happy to connect with whoever wrote that.
I'm not sure who it is, but I will.
Okay.
I hope that they hear you and reach out to you and anyone else who might be interested in that kind of thing. I just wanted to ask a quick question from hopefully Chris, hopefully quick. An interesting part, I think, of your findings, Chris, was this idea of different neighborhoods. Like you live in a neighborhood, but you're also going to school in a neighborhood. And you talked kind of a little bit about some of the differences there, but I'm wondering if you could maybe give us an idea how that might impact health differences. I know that wasn't quite in your research, but I'm wondering if you might have thoughts on that.
Well, we focused on safety here. So the experience of safety in schools that were remote from the home neighborhood was lower on average than other exposures. That discrepancy, you don't see that discrepancy as much for kids who are living in their home neighborhoods. You can take they're in their home neighborhood, going to school in their home neighborhoods. So you can take various radii around the school and look at safety reports around that school. That doesn't differ that much from what their school reports don't differ that much from their other reports. So what's happening is that there's something about that remote experience of school, and the school neighborhood is something distinct from the residential neighborhood that's leading to lower levels of safety. We know from other research that EMA reports of safety are associated with physiological stress. So we've done some research on hair cortisol concentration and seen associations between lower levels of average safety reported on the EMA and higher hair cortisol concentration among youth, which has then longer term implications. So the research is in its infancy, trying to understand really these moment-to-moment geographic exposures, EMA reports of experiences, and continuous measures of physiological stress. I think that is a really important next step in the research to try to be able to get that physiological stress variability as linked to in the moment subjective and spatial experiences. But we're getting some evidence that safety is a significant predictor of physiological stress.
Makes sense. Melissa, if you'd like to go ahead and go ahead with your discussion, and then we can have more questions and discussion.
Sure.
Thank you.
So I would like to thank all the panelists for your excellent presentations and your Q&A. I really think the themes that are importantly showcased here are that different elements of the ecosystem which surround our children impact their opportunities for holistic health in that present moment, but that translates to school success and their lifelong health trajectories. And so I'm a public health nurse and researcher, and I work with communities to improve local food environments. And in my work and in the presentations that we've heard today, we can see how how powerful those individual elements of the community ecosystem can be, whether it's access to nutritious food, like in my work, or out of school programming that we heard about in panel 1, or the green spaces, the social cohesion opportunities, the safety of neighborhoods, or the quality care models. Each of these factors plays a critical role in shaping the health and academic success trajectories of our kids. And I'd like to underscore that these elements are not existing in isolation. And so while we talk about them sort of in isolation, they're deeply interconnected. And together they're forming this complex ecosystem that can create a lot of challenges or a host of opportunities for children to thrive and flourish. And so with that in mind, I think there are 3 key messages that I'd like to emphasize. First, the community ecosystems that surround children are impacting safety, play, physiologic stress, and subsequently their health. And that ultimately translates to school success. And yet we also know that the ecosystems across communities are not the same. And we have to really remember, as Dr. Browning pointed out, that children are spending a lot of the time outside of their home neighborhoods too. And so when we think about the ecosystem that's supporting our youth, we have to consider both their home communities and their school communities. And for example, when we think about access to parks or green space, we need to think about that both in the home environment, the school environment, and together, how are they providing opportunities for children or not providing those opportunities if they don't exist to build those lifelong behaviors to really support school success and health around physical activity, social skills, emotional regulation, and more. And as showcased by the data from all the panelists, the context matters, right? Children from communities that were experiencing low incomes were less likely to have opportunities for social cohesion in their home neighborhoods, and they're more likely to spend time outside of their home neighborhoods. And boys in low income settings were really much more likely to experience lower levels of safety in their school neighborhoods. And we saw that policies that were aimed to reducing sedentary behavior were much more effective in spaces that actually had, abundant green spaces. And then the quality of those spaces really mattered. And so whether there was lawns or playgrounds or sidewalks and structured programming really influenced how often those spaces were used. And so the community ecosystem context matters, and it really varies widely across communities, and again, can create these opportunities and barriers for our children and their families. And because context matters and community ecosystems are different, I think the other common thread, the second message, is that it's important that we're measuring these things, because if we're not evaluating and measuring the ecosystems, we can't understand sort of what the needs might be or their impacts on health. And the methods that we're going to use to assess ecosystems is actually really tricky, right? Because ecosystems are a tangled web of multiple things kind of all interacting together, but we have to do that work. And the panelists provided ways in which we can actually begin to unpack those ecosystems where children are learning, they're living and playing, using geospatial and population level data, health outcomes data, observations at parks, biomarker and cellular level data, thinking about our systems and geospatial qual data possibilities that didn't exist previously, looking at costs and school neighborhood safety. And we can use things like technology and health sensors and EMAs to really see where our children are and how their environments are contributing to their health and their choice in health behaviors. And that's critical to informing how community ecosystems are similar or different. And these methods can really help us understand what needs communities might have, whether it's food, housing, playground, safety, and how those elements of the ecosystem, like safety or access to green space, contribute to the children's health outcomes, either individually or as a collective. And together, that data can really help to identify like areas that are most in need. And the data that's generated is often most trusted, and the research often is most effective when it's implemented in partnership with the community. And so you could really hear that that when the community is involved, they can really help to sort of understand and trust the data. And then when the data is there, communities, nurses, the interdisciplinary teams, because it takes everybody, can really work together to identify those community strengths to build upon identify priority areas for growth. And this data also helps us understand what interventions are working, where the gaps are, and how we can better support children and their families. And that brings me to my last takeaway. Nurses are playing a critical role in shaping the community ecosystem. As trusted professionals, nurses in all settings are uniquely positioned to be able to collaborate to really shape healthier community ecosystems. For example, we heard how nurses can help advocate for school playgrounds to be accessible during non-school hours. And we can support, making accessible outside of school programming for positive youth development and physical activity, or we can support community nutritious food access. And nurses are already deeply embedded in communities. To name a few, there's public health nurses, school nurses, and nurses in places of worship, which is something that we all are really familiar with on this call, and that we're already working in spaces where we're working directly with children and their families in the places where they manage and maintain their health each day. But increasingly, nurses are expanding their reach into settings like libraries to meet families where they are. And nurse researchers are partnering with communities and interdisciplinary teams to really develop and/or test really innovative interventions to create a more supportive ecosystem for health. And so while these nursing activities are pivotal, and I think they are going to keep pushing health outcomes forward, we still face that sobering reality that our health outcomes for today's children continue to fall behind. And so in response, nurses are stepping up as innovators. And I was so excited to hear again about the neighborhood nursing model, because developing and testing promising new models of care like neighborhood nursing that bring services closer to where families live, learn, and play have such potential to shape and shift the ecosystem in those communities that really supports and promotes health in the targeted universality that Dr. Stenson was talking about. And so this innovation that's showcased with neighborhood nursing will undoubtedly pave the way to building a more connected ecosystem of care that meets families where they are and helps our children flourish both in their health development, but also in school. And so those structures and supports in those communities really do matter. So in conclusion, our work as nurses, which works across disciplines, across sectors, and in true partnership with community, is really essential to strengthening the ecosystem that supports our children throughout their entire lives.
Thank you so much. I wanted to start the second set of questions. I'm wondering if any of the speakers or the discussant has questions or comments about the other presentations. There's some crosstalk that we might get here. Sarah, I think if you're talking, you're muted.
I'm not. I'm no more doing the fish space.
Oh, okay.
No,
Sorry.
but what I was thinking, thank you, was there's so much synergy across the presentations. I think especially on building upon what's already in communities, what could be strengthened in communities, and people being able to say how they feel about where they are, and then being able to bring services there.
Yeah, I'll add. I think think there's a really great opportunity to use some of the methods that Dr. Browning had been talking about. We've we've done some work where we've created EMA surveys where when people go in parks, they get a trigger for a survey. And so really, when we look at the possibility for parks and what they can do and the low use, really getting that nuanced data to understand who's using it, why, with who made the decision to use it, and even understanding as people go throughout the day, whether they're near parks but not using them, and getting more refined information, I think is really going to push the field forward to help us understand how can we really increase the utilization of these important assets.
I also, Baltimore isn't known for its green space, but we actually have more green space per person than any other major city. And I think there's a huge opportunity in Baltimore and other cities that do have a lot of green space to look at how much is a park and how much is the neighborhood, because we've got beautiful parks that are in neighborhoods that are very underinvested with, crumbling stairs and poor schools, and so how much to see how much is a park effect versus a neighborhood effect, I think would be really interesting.
There is kind of a, Chris, did you want to?
Well, I would just quickly add that, a lot of the research on space and mobility right now is based on large scale data sets that are from volunteered sources like SafeGraph, cell phone data, smartphone data. Those studies are great and important, but the kinds of studies that I think we need, that Natalie is doing, and others who are looking at in a more focused way on ecology is relevant for school, are collecting survey data and integrating it with smartphone and geographic and EMA data. And you really need to collect that original data to be able to get the insights necessary to understand how people are using spaces and their differential experiences. You can't get it from device data. And so it's just a plug for additional research that combines these different sources of information.
Thank you. And on that note, I think we will close this session and then I'm going to turn it over to my colleague, Karen Keel, who will moderate the next session. Thank you so much, everyone.
Thank you.